Welcome. Welcome, everybody. Welcome, folks, to a bonus episode of Gateway Center of Excellence in Rural Health lecture series, where we are opening the gate to understanding rural health. Today's date is August 7th, 2025, and the topic for today is Don't Shut the Doors. Why rural emergency departments must stay open. My name is Sage Milne, and I'm your moderator and a research assistant at Gateway Center of Excellence in Rural Health. And I'm so pleased to be joined by an incredible group of speakers, including Dr. Sarah Giles, who is the president-elect of the Society of Rural Physicians of Canada and an associate professor at the Northern Ontario School of Medicine, NOSM. Dr. Fraser MacKay is the chair of the Canadian Association of Emergency Physicians, Rural, Remote, and Small Urban Section, as well as an associate professor for the Dalhousie Faculty of Medicine. Finally, Dr. Ken Milne is an associate professor at the Schulich School of Medicine and Dentistry and the creator and host of the podcast series, The Skeptic's Guide to Emergency Medicine. Before we begin, I want to acknowledge the land. Gateway is an organization dedicated to promoting the health and well-being for the diverse communities that call rural areas home. This can include rural, remote, and Indigenous people and lands that continue to face inadequate access to health and healthcare services. As a brief note, the views and opinions in this webinar may not reflect Gateway's, but we believe in providing a platform for meaningful discussion. And now I will pass it on to Dr. Sarah Giles to talk about what brought us here today.
Good morning. Thanks for having me. I'm coming to you from the lands of Treaty 3. I'm currently based in Kenora, Ontario, which is the most westerly community in the province. What brought us here today? I think probably two things. One, years of systematic underfunding and hollowing out the care and services offered to rural Canadians. And number two would be Andre Picard's recent article in the Globe and Mail. As many of you may know, Mr. Picard is a health reporter for the Globe and Mail, and he had a recent column where he stated that, I'm going to paraphrase here, rural hospitals, mostly ERs, should just close, were glorified walk-in clinics, and that there should be more paramedics to take patients from rural walk-in clinics to real emergency care in tertiary centers. Clearly, this is a statement that most people living in rural and remote communities would disagree with. And I think actually most people who are familiar with the literature or who maybe work in an urban ER would say this is not the greatest idea either. All right. As a member of the Society of Rural Physicians, I am the president-elect. We put our heads together after Mr. Picard's article to say, well, first of all, we were a bit shocked by what he said, but he seemed to strike a chord with some people who said, yeah, that's a great idea. And we sort of thought, okay, how do we talk to people who think this is a good idea and make them understand that this actually isn't based in evidence and would actually probably hurt people rather than help them? So we looked at it through a bunch of different perspectives. And I think, first of all, if we look at the evidence, there's actually no evidence to suggest that rural hospitals provide care that is any worse or any better than urban centers. This is in Canada. In the US, there's a little bit of data to say it's about equivalent. Now, we know that in medicine, there's something called the golden hour, and that is the hour after someone has a trauma or where something life-threatening might happen, for instance, a massive heart attack or stroke. The faster people get care in that first hour, the better they do. If you look at outcomes in rural places, because we tend to cover large geographical areas, that golden hour is sometimes stretched to the golden 4 hours it takes to get to the hospital, or as I sometimes sort of sarcastically call it, the golden day or the golden week, which is when the fates come together to screw up your best laid plans. There's a snowstorm, there's a tornado, the road is washed out. There are all these things that conspire to keep very sick people in communities that have some care, but perhaps not all. Now, Mr. Picard suggested that we should move really sick patients from small centers to big centers. Now, for the most part, actually, rural centers do a great job of keeping their own. And we're actually great bang for your buck because people come, they see us, we might admit them and keep them. We're saving money on transfers, we're saving money on, multiple people billing for services. But there are people who do need to go to bigger centers. We do not want to pay for a system where there's a board neurosurgeon in every small community. We want there to be super specialists in some things that are rare, such as neurosurgical catastrophes. There aren't actually tons of them, and we don't need millions of them, but we do need to be able to access them. And in fact, most of Canada has a hub and spoke model where there's a tertiary care center. And what do I mean by tertiary? I mean a big center with most of the specialties there. And even then, if we think about things like transplants, not every major urban center will do this. There'll be a handful of super specialty services across the country. So we have the smaller centers that feed into bigger centers. And these, hub and spoke models work quite well. Now, how do you get from a rural community to a bigger community? Mr. Picard says, well, just create more paramedics, just have more transfers. We already struggle with the current model. I can't imagine trying to do more. My hospital sees somewhere between 20 and 30,000 emergency patients a year. Now, if we say that a good 2/3 of them need more than a walk-in clinic model, that would be moving somewhere in the neighborhood of 20,000 people. And it's not as simple as just jumping in your car. A huge number of my patients live in poverty. They don't have vehicles. They don't have a way to get into the hub of Kenora from our 11 surrounding communities, let alone to a place like Thunder Bay. And our tertiary care center is Thunder Bay. That's a 5.5-hour drive, or a plane or a helicopter. So it's not as simple as saying, oh, everyone can drive or just take an ambulance. We have 3 ambulances in the region that are by road, and we have 1 helicopter. We could go through that in an hour if we said we're not doing anything more than walk-in clinic care, and then we would have nothing. One of my predecessors, Sean Moore, was on the show talking about air transport. He's fabulous. And we work very closely here in Kenora. But they've done a tabletop exercise where they showed that there would be in the neighborhood of 2 excess deaths a day if we closed our emergency department. I think one of the biggest things to say to Mr. Picard and those who think like him is that Canadians, regardless of where they live, deserve timely access to life-saving care. There is no asterisk on the Canada Health Act that says applies only to urban people. Okay. We know already that people who live in rural and remote communities have decreased access to health. It's not like everyone lives within walking distance of a hospital. And I think some people have this sense that every tiny community in Ontario or Canada has its own hospital. That is completely untrue. The closest hospital to me is in Dryden, which is about an 1 hour and 40-minute drive to the east. And if I go west, I'm looking at Winnipeg, which is 2.5 hours. People deserve care that can stabilize them and deserve care that can keep them somewhat close to home. We already have patients who forego going to Thunder Bay for their radiation or specialty procedures because they don't want to do that far away from home. They want to spend time when they're sick, close to their home, close to their pets, close to their loved ones. It is simply not good enough to say, no, but you live rurally, that's a choice. People talk at length about the economic engines of Canada. What are those? Rare minerals, the oil sands, all of these different things are actually happening in remote and rural places. Urban Canadians vacation in rural places. They drive through rural places. Everyone deserves timely access to care. Not everyone deserves an MRI in their backyard, but they should be able to be stabilized and sent on. So, those were our big take homes to Mr. Picard. And I would say, I would welcome him to hang out in my ER anytime to see what we actually do, because I think we punch above our weight. I think we are great bang for your buck. And I think our patients rely on us and need us. Thanks. I'm going to pass this over to Fraser.
All right, thank you, Sarah. It's a hard act to follow because I mean you hit everything and I agree entirely with everything you're saying. And I don't think Mr. Picard had an intentionally negative spin on things. I think he, like the rest of us, is overwhelmed by the problems and is trying to think what can we do? Because we've gotten to this point in healthcare in Canada and it is not a rural or an urban issue. It is a Canadian problem. The emergency department in Delta, BC closed overnight the other night. That's not exactly a rural and remote location. So, so my perspective, my sort of introduction to my part in this is from the Canadian Association of Emergency Physicians standpoint. So emergency departments are the front door to the healthcare system. Should it be that way? That's another matter. But hospital crowding and ED closures, we know that they increase morbidity, they increase mortality. So this is population level healthcare. And we need to be clear about who is ultimately accountable for that. And it's not the individual doctors and nurses on the ground. And so I want to emphasize that all stakeholders have to collaborate. And so what does my organization, CAEP, advocates for the provision of high quality emergency care at all levels in all sites across the country. And we emphasize the need for collaboration amongst the stakeholders to address these challenges. And these are not catchwords we're using. These are fundamental concepts that are critical to improving the situation. So recognizing the complexity of it, it's very, very easy to get overwhelmed with the staffing crisis, with the closures, with the transport issues, with the primary care problems, with the access problems, with the hospital, right? It's overwhelming for any one person or any one organization to manage. So what CAPE's done over the last few years is they commissioned what's called the EM Power Report, which stands for Emergency Medicine Patient Care Organizational Workforce and Ecosystem Redesign. So a pretty ambitious title for sure. And it's a big document. It's about 275 pages. But it's broken down into 5 sections. And I'm going to ask the host, I'm going to drop a link into the chat because this is publicly available information. But basically, we have broken down the overall crisis and emergency medicine into 5 overlapping sections. So the shared purpose and coordinated mission is section 1. And that is basically what I was talking about, that there has to be broad collaboration at every level from the frontline provider to senior federal healthcare leadership. Everyone's got to use the same language and understand the problems because there's so many perceptions, there's so many myths. The problem with emergency departments is primary care. No, it's not. Those are 2 problems that are related, but you can't fix one without the other. And the human health resources, and et cetera, et cetera. There's so many overlapping problems, and we need a coordinated approach. So section 1 of the Power Report talks about that. Section 2 is called One Network, Many Access Points. And that is really what gets to the heart of the closure situation and the rural versus urban. And that we need a provincial level leadership on this, that there have to be integrated networks of care to address the concerns that really sparked a lot of this discussion about the consideration of if you can't fully staff an ER 24/7, is it better to close that and redirect resources to a larger center? And as Dr. Giles pointed out, no, A, there's no evidence to support that at all. B, there's clear harm to the local communities. And C, it's putting the cart before the horse. We still have finite resources. And so it's much more about the accountability and the integration and the use of the resources we do have, and that requires a coordinated approach. And so there's a really good section on that in the report. Section 3 is about access block and accountability. And these are my real areas of focus in my work. And the accountability piece is critical, and the access block is critical because what we have is we have the situation where everything leads to everything else, which ultimately leads to the human health resource crisis. So emergency physicians, a full-time job used to be 15, 16, 17 shifts a month. It's now averaged at about 12. That's considered a full-time job for physicians that are practicing in the emergency departments today. Not that there aren't lots of docs doing a lot more than that, but as I've said a few times publicly, the job is becoming so physically and emotionally taxing that people really are struggling to work the number of shifts they used to because the job has gotten so much harder. You know, I did an 11-hour shift that was supposed to be 9 hours last night in a rural department where it was just me after 5 p.m. And I saw all my patients. This is a rural department that's had a temporary overnight closure for over 3 years, and it's still listed as a temporary closure. But because it's been set in stone for 3 years, it's no longer listed as an emergency department closure. And this speaks to the struggle we're having to have accurate information out there. And so that's why we need really what CAEP would like to see is federal and provincial governments declare this is a crisis. This is an emergency, right? It's slow moving, and I really equate it the challenges in emergency medicine or in healthcare in Canada is people say, the coming crisis, the coming disaster. We are right in the middle of it. We are seeing it, and we know patients are suffering and patients are dying because of it. It's a very hard thing to prove with data. A, because we don't have the data. And B, if you close an emergency department for any period of time, you don't know what happened to the patients that didn't show up. There is no way of tracking that. A lot of it is sort of intuitive, but it's important that we don't let our instincts and our anecdotes run our systems. We need data. We need collaboration at high levels. And so the CAEP Power Report is guiding our organization's strategy right now, which is focusing on three overlapping sections: the human health resource crisis, which is huge, and that's the real rate limiting step. If you say, oh, well, we'll replace this rural emerge with virtual care, A, that's not acceptable, and B, you're still using a doctor somewhere. And when that doctor is attending that virtual care, they're not working in primary care, they're not working at an emergency department, they're not working anywhere else. So you've still got this finite resource. You're just pushing the problem somewhere else. And then all of this overlaps with the burnout rate, which relates to things like hospital capacities, which is a critical driver of emergency department outflow. So there has to be a public understanding that the main driver of long wait times in the emergency department isn't actually the primary care crisis. Yes, there's a lot of patients suffering because they're waiting for 8 and 10 and 20 hours to see a doctor. But their problems, by and large, are not challenging for the emergency physician. It's just the emergency physician can't get to them because their beds are filled with admitted patients because the hospitals are running at 100% capacity. That is inexcusable. Basic disaster planning for a hospital states you should never run a hospital at 100% capacity. If you do, you are in crisis. So when you're over 100% capacity, where do those patients go? They emerge. And then the wait times go up, the workloads go up, the people that leave without being seen go up, et cetera, et cetera, et cetera. That makes our job harder, that makes burnout worse, and that makes it hard to recruit. So, and so CAEP aligns very much with the SRPC in our approach to this, which has to be collaborative. And a really critical thing to understand, as I say over and over again, the problems in emergency medicine are not problems in emergency medicine. They're problems in healthcare. And you cannot address primary care at the expense of emerge care and vice versa. And excuse me, that's embarrassing. So um, so we've got a few action steps that we emphasize, which is we need communication at all levels, and that really has to be senior provincial leadership. We need an intense focus on increasing hospital bed capacities everywhere. And then we need to increase capacity for alternate care. There's a common term called alternate level of care, and I think there's a mental association with nursing homes, but alternate care simply means not in the hospital. And that is physiotherapy, that is home care, and such simple things as there's this belief that to care for someone who's had a hip surgery, you have to be a physiotherapist. No, that's not true. Family can help. Patients can help. We need to empower people. And so this gets to very high level social infrastructure. Again, this is so far beyond emergency medicine. But all this suffering becomes evident in the emergency department. So we are the poster child. And what we are saying is we are really good at our jobs, right? Rural, remote, nurse practitioners, locum traveling physicians, family physicians. We're running the majority of the emergency departments in the country. And yes, do we have the same capacity as the major trauma centers in the cities? No. Do we have the capacity to manage the sick patient that walks in the door? Yes, we do, if we have those resources in place. And so we want to emphasize that the care you get in an emergency department should not and is not dependent on the size of your community. It's simply dependent on being given the basic resources we need and the support we need. And we cannot fix that by focusing on the emergency departments. We have to spread this across the entire system. All right, that's enough ranting from me.
Dr. Ken Milne, do you want to share a little bit?
Yeah, I'm happy to. Listening to the first two speakers was very enlightening. I'd like to mention that I'm the one speaker that practices in the Gateway catchment area, and I've worked in about 30 different rural emergency departments in Ontario over the last 15 years, helping to cover those departments while still working full-time in an attempt to keep some of those departments open, working with other healthcare professionals. But I do need to mention the 5 things. And I'm so glad that Fraser mentioned 5 things because it's my favorite number. So I'm just going to go with 5. And so the first thing is Sarah, Kenora. Oh my goodness, what a great place to work. One of those 30 places has been Kenora, Lake of the Woods. Ah, it's God's country, as I say when I go up there. People like you, Sean Moore, some of the best family doctors and emergency doctors I've ever had the pleasure of working with. These people are highly skilled, highly talented, and probably the most important thing, they care a lot about their community. So going up to Kenora is one of the joys that I've had professionally working there. And so Sarah, and to your team up there, oh, well done. Second thing, though, is I'm going to push back against Sarah here and say there is evidence that rural physicians provide better care in the emergency department if you count metrics like time to first physician contact and time to discharge. All of those time-based metrics are actually better in rural emergency departments, and I've published on that. Also, I've looked at heart attacks, and back in the day when we were more likely to give clot-busting drugs, because this is a general audience, thrombolysis for all the other people out there, but clot-busting drugs, we did a barn door to needle time and looked at the times in rural areas, and we found that we exceeded that 30-minute standard and did better than our urban counterparts. And I'm not disparaging the urban counterparts. I'm just celebrating the fact that we can work well and we can work quickly, and we have evidence that we can provide actually better care. We also have another study that did barn door to pneumonia treatment, so time to antibiotics for pneumonias. Also, for this second point, Gateway had Luella Vaughn on here talking about another country's implementation of station of care, thinking, and I understand, thinking that, oh, if we just centralize some of this acute care, we could get some economies of scale and things like that. And unfortunately, the data suggests it doesn't work out as anticipated, except for some very niche things, like Sarah mentioned. You know, if you need neurosurgery, you're going to need to be transferred. If you need angioplasty, in other words, opening up the heart blood vessels with catheters and little springs in the heart and stents to open them up, yeah, you're gonna get that care at one of those urban centers that can't be provided. But for the vast majority of healthcare, whether it be primary or emergency care, that can be delivered very well in a rural center. Now, to the Andre Picard thing, this is so hard because I respect him very much, and I hope he will maybe clarify. Maybe he has clarified, and I just haven't heard it yet. Or maybe he could come on a Gateway lecture and talk about this and explain what he meant, because maybe I'm misunderstanding what he said. I'm trying to steelman his position because I worked 3 12-hour shifts, not at my home site, but at 3 different rural sites the holiday long weekend. And I can tell you, it was not a walk-in clinic. There were some seriously ill patients because you know what? Heart attacks happen everywhere. Strokes happen everywhere. Traumas happen everywhere. And they don't just happen when the sun is up in the sky warming the earth. So you can't just have it 8 till 6 or something like that. And I don't want to say this, but I'm going to say it because, you know, frontal lobe. I felt like I was being urban-splained. And, you know, Sarah, you invited Mr. Picard to come and spend some time with you. I will extend that invitation to him. If he would like to shadow me in one of these walk-in clinics, please come join me for a 12-hour shift. It's usually about a 2 to 4 hour drive to get there, the 12-hour shift, and a 2 to 4 hour drive home. So pack a lunch. Fraser, I'm sure you would extend an invitation for him to come. And again, I really don't want to beat up on Mr. Picard because, again, I'm a fan. He does great work and he's a great advocate, but we can all misspeak, and perhaps that's the case here. But isn't it great that we can turn it into something positive like Gateway has and have us come together from rural physicians, from the Rural Society of Canadian Physicians, and have the Canadian Association of Emergency Physicians come together with Gateway and talk about some common ground. So that's the third point. The fourth point is postal code medicine. And I have said this so many times, and I think, Sarah, you mentioned this earlier. Access to appropriate, timely emergency care should be more based on your need, not on your address, i.e. your postal code. I don't practice postal code medicine. What I do is deliver care to the patients that need it and the appropriate care, and then have a robust system to transfer them out of that postal code to an urban postal code that can provide some of that care that we cannot do and we should not be doing in rural areas. And then the final thing is, Fraser, in your CAEP power document, EM power study, you know, that is like what, a couple hundred pages, you mentioned solutions. And so here is my solution that I'm going to throw out there. And that is to apply John Rawls. He's a philosopher. John Rawls came up with a philosophy of the veil of ignorance. Oh, yes. Put that veil of ignorance so you don't know if you're somebody living urban or somebody living rural. And the decisions that are made about rural healthcare should be made with that veil over everyone's eyes, not knowing if they are going to be living or their loved ones, and Sarah mentioned pets, and they are part of the family, are living in a rural area. And that's how we should make decisions, because there's good evidence for these moral societal decisions that if we use that framework, that John Rawls philosophy of the veil of ignorance, we're more likely to make equitable decisions about society's needs. So those are the 5 things. Kenora rocks. We do provide better care in some areas, in rural areas. We're not a walk-in clinic. It's not postal code medicine. And put that veil of ignorance on before you make decisions.
Thank you so much to all the speakers who have shared all this wonderful information. Now, if anybody does have any questions, I encourage you to put it into the Q&A down at the bottom of your screen. I do have some questions I would specifically love to ask the speakers. Dr. Sarah Giles, in a previous episode of our webinar series, we had Dr. Sarah Newberry, a colleague of yours from Nawson, discuss retention. Why is it the key to recruitment? She highlighted that there was a need to retain rural physicians to recruit new doctors. Doctors who work in rural communities and emergency departments are aging. How do we retain these workers to potentially prevent closures?
We are aging. It is my 20th med school reunion this weekend, so it's a great time to remind me of that. First, I want to say we're talking. We're hearing a lot of bad things about rural medicine. That we're burnt out. There's moral distress. We can't staff it. I firmly believe I have the best job in the world. I get to use my skills and grow them, whether I want to or not, sometimes with what's in front of me. I work with amazing nurses, amazing paramedics, amazing consultants, and I can't think of another job I would rather have. And the vast majority of my colleagues would agree with me. Maybe they'd say they would like a little bit less of the job, but I think we all love it. So how do we get other people to understand that we do amazing things and love it, and they should come and join us? And how do we retain people? I think the first thing is med schools across Canada are based in urban centers, and the vast majority of people who enter med school are from urban communities. And those people need to be convinced that there's a rural life worth living. If you are from a rural community, you've experienced rural, and you are far more likely to work in another rural place. So first of all, look at who we're letting into medical school. How else can we retain people? First of all, pay us a fair wage. Understand that the patients that we treat tend to present a bit later because they're tough and probably in a bit of denial. They come long distances. Every single patient I see, I have to say, how are you getting home? Because they might have come from a community 2 hours away. And if they came by ambulance, they don't have clothes, they don't have shoes, and they don't have a ride at 2 a.m. You need to allow us to upskill as things change. If things have changed in 20 years, if there's a skill set my community needs that I don't have, right now it's up to me to fund that. But the Society of Rural Physicians created this national upskills program where we got several $1 million from the federal government, and we let rural physicians apply for the money, where we paid for a locum, which is like a supply teacher for doctors, to come in to take their shifts. We paid for their travel and accommodation. We paid the people training them up to a total of $35,000 for a month. Using about $7 million, we upskilled about 350 doctors to help them give better care to their communities, keep people close to home, decrease those moral injuries where you have someone in front of you and you can't help. It's amazing bang for your buck. The governments need to keep funding things like that. You have to allow for a system of locums to come in to, people like Ken, to help us on long weekends, to help us in the summer where people want time off, to help when people have a baby, or to help just when, these life crises happen. Your kid gets sick and is in the hospital, for a year or something like that. We need help, and there needs to be programs that allow for that to happen. And they need to sometimes understand that a community needs more physicians than it has. And, one of those spots might need to be constantly filled by a locum. Finally, and this is a little counterintuitive to people, but hospitals get some money from the government, but for capital equipment purchases, they don't. And that is largely up to the community to fundraise. If you live in a rich community, that's not a huge problem. You have your black tie dinners, you do what you need to do. If you live in a poorer community, it's super hard. And that creates communities of have and have nots. That means that you can have flashy things where in one community and not have them in the next. There needs to be some more equitable funding for communities that are not rich and need capital equipment. So those are, I think, the main things we need. So we need to be paid fairly. We need to upskill. We need to allow for leaves and locums, and we need some funding for capital equipment.
Thank you so much. For anybody that is looking for the link that Dr. Fraser MacKay was talking about, if you scroll down, Erica Maloney has posted it within the chat. Sorry, within the Q&A box for anybody to access. I do have a question from Amanda. Is there, and I'm going to direct this to Dr. Ken Milne, is there much research in Ontario and Canada that local governments can draw from to identify what specifically to advocate for, try to move towards, and collaborate to create?
Yeah, there's a research base on rural healthcare, and some of it's generated from Ontario itself, some's Canadian, and a lot of it actually comes out of Australia as well, because they're facing similar problems. But there is an evidentiary basis for doing things. What I'd like people to avoid is trying to employ what I'm phrasing now, zombie ideas. That we need to employ these ideas that have been tried before, shown not to work, and go, okay, maybe we should try it here. And that gets back to Luella Vaughn's data that she was on earlier with a Gateway lecture talking about centralization of acute care. Because again, it intuitively makes sense from maybe a business standpoint, but from a rural reality, living in Canada, where one winter I got snowed in Kincardine. I went up there to cover a December 23rd shift to help keep their emergency department open. And I don't think I left until December 26th, because every single road was blocked due to snowstorms. And so I was storm stayed up in Kincardine. What was nice about that is the local pharmacist, who also has been on one of the Gateway lectures, Kristen Watt, was kind enough to take me into her home over the holidays and make me feel welcome. Again, going back to Sarah, rural places, what a wonderful place to live and work. Somebody in the chat already said they want to move to Kenora after what I said. Super. But yeah, there is an evidentiary basis. And if any of those people want to reach out to me, I've been doing research, rural research, for probably 30 years now, and have quite a thick portfolio that I could share with them.
Yeah, Dr. Fraser, I'm actually going to turn to you and look at the fact that we have lots of different speakers. We have somebody from Northern Ontario, somebody from Southwestern Ontario, and you coming all the way from the Maritimes. And I was wondering, the Canadian Association of Emergency Physicians is a pan-Canadian organization. Healthcare is federally funded, but provincially distributed. What differences have you observed in rural hospital closures between different provinces?
It's an excellent question. The most critical part of that answer is that we don't actually know all the differences, because reporting is very inconsistent within and between provinces. There are some provinces where we just don't have the data, and there are some provinces where the definition of a closure is variable. So if you have a larger emergency department that has different zones, sometimes you've got a rapid assessment zone as well as an acute zone. If the rapid assessment zone is closed because of lack of staffing, that's not going to be listed as a closure, but that's going to decrease your capacity to see patients by 50, 80%. And there are some provinces that publicly advertise closures, and there are some that don't. There's situations like one of the departments I work in where, because there's been a temporary overnight closure for 3 years, it's not listed anymore because it's a planned schedule. And then there's huge variations, like in Quebec, they tend not to suffer rural closures the way the rest of the country does because of government involvement in mandating where physicians work for a period of time. But that comes at the detriment of some of the larger centers because the government is controlling a finite pool of physicians and telling them where to go. That significantly impacts recruitment, retention, and staffing of the larger centers, right? So there's a lot of challenges in that regard. And it gets it gets really, really interesting. So one of the sites I work at in New Brunswick, it's a rural site. We don't have a CT. We're only open 8 till 8. But we're not super rural. We're an hour in 3 different directions from 3 cities. And each of those cities is in a different health zone. So that rural site gets a ton of patients from the 3 different health zones, and the computer systems don't communicate. So I don't have a lot of access to information for a lot of my patients, but they are driving. It's only an hour's drive from the city, and they are driving there because the wait times are so ridiculous at the tertiary centers. So they'd very happily drive an hour, knowing the wait time to see me is maybe only going to be 4 to 8 hours versus the Lord knows how long, if getting seen at all, in some of the larger centers. Ironically, a lot of those patients have to turn around and send to the larger centers if they need advanced imaging. But the really significant point here is that, if I'm seeing 40, 50, 60 patients a shift in that rural site, and a lot of them are coming from the larger centers, what's going to happen to those larger centers when they close that rural emergency department, right? So you cannot separate the problems in urban emerges and rural emerges, right? They have to be an integrated system. And so that's one of the really other big challenges in accessing accurate data across provinces about closures. It's not just when are you closed and how long are you closed for, it's where are those patients being pushed to and what is the capacity planning for those patients that can't get seen in that rural site. And we don't have that almost anywhere. There's places that say they have networks of care. There's some lip service to it. British Columbia is a glaring example, being how much they've been in the press in the last couple of weeks for closures. But it's the same in Alberta, in Saskatchewan. They had a trial virtual care model for 5 sites that weren't able to keep the rural sites with an on-site physician all the time, and that trial has expanded to 27 sites the last time I checked. Lord knows what it is now. And on the virtual care system, and they're all credit where credit is due, they're doing everything they can to try and see patients. They clearly state this is a short-term stopgap. They are trying to recruit more doctors, but at the same time, they're expanding that system. So they're actually changing from a staffed emergency department to a virtual care department. And that's a whole other topic I'm not going to get into now. And so then the question becomes, so are they calling that a closure or not? Our association has a pretty standard stance that if you do not have a physician on site, you are not properly defined as an emergency department. Emergency physicians are defined more than anything else by their location of work, not their exact certification levels. If you work in an emergency department, you're an emerg doc. So yes, you can provide good care virtually if you have on-site resources and really experienced and competent nurses and a very, very expensive virtual care system. It's actually much more expensive than just having a doctor on site. It offers much slower care and it offers much more limited care. Are they calling that a closure? I can't answer that question. So once again, this comes back to not just data collection, but understanding the data. And so until this is mandated and publicly accessible, it's really hard to know exactly what we're dealing with, other than the fact that we do know that closures are increasing across the country.
Thank you for discussing all that. And it's really interesting to see how the different provinces do vary and how the lack of data really limits action. We do have a question in the chat from Dr. Sannon, and I kind of want to expand on that from Gateway's end. There are many people that are involved. Healthcare is a team. And Gateway found that in a survey of local healthcare workers looking at shortages, the largest shortage in Huron County was nurses. One of the more common reasons for closures, at least in Ontario, for closures in the emergency departments was nursing shortage. How do you envision a future where you can manage to recruit? And what does that really mean for rural emergency departments, as we lack doctors and as we lack nurses? What is really the way forward? And I'm going to direct this to Dr. Sarah Giles.
Thanks so much. First, I want to say, like Fraser, I've been so impressed with what you said. So happy to have you represent me at the CAEP level, and absolutely agree that, you know, if urbanites are say that, you know, virtual care is the solution for rural centers, and I welcome them to bring it into urban centers. And I think that'll put an end to it quite quickly. In terms of how do we get rural nurses, I think, again, it goes back to where are we looking? If we're looking for urbanites to come to rural centers, it's probably not going to happen. We probably want people who are from those communities who would like to stay in them. So that goes to, so in Kenora, we actually have a pretty good pipeline of local nurses. Why is that? Co-op students come and work in our hospital and get really excited about their future careers. We have, sure, there are students that go away to the bigger universities, but we actually have a organization in town called 7 Generations, where you can do the vast majority of your nursing training in Kenora. So your classroom stuff in Kenora, your practical stuff in Kenora. And that really allows people to stay closer to home. It's been very popular with our Indigenous students who come from the region. They can, if you know, they can commute in from their communities, which are up to an hour or 2 hours away, which is still, you know, far and not ideal for them, but it allows them to be closer to home and closer to the communities. And these folks are the ones that we see who stay long-term, who invest in their careers, who invest in the communities. Nursing is a really tough gig. When you compare it to, and we know it's mostly filled by women, it is comparatively dramatically underpaid. If you do a 4-year nursing degree and you do a 4-year trades, which, you know, more of a male-dominated profession, the pay is outrageously different. Our nurses are working 12-hour shifts overnight half of their career. Okay, that is really not reflected in their wages. They are increasingly facing violence, facing belligerent patients, facing burnt out doctors. It's not a fun place to work. We need to not just look at improving wages, but improving working conditions. And while we hold our staff to very high levels of behavior and professionalism, there's nothing like that on the patient end. There's no way to say to a patient who has physically assaulted us that they can't come to the ER, because that's not safe. But the police routinely bring us people who they can't control in cells. You know, like I myself was attacked at Christmas time about 2.5 years ago. There are some problems there that we need to take seriously and deal with at institutional levels and a societal level, where if you find out that your friend or family member has acted in an outrageous way, that there are social consequences to that.
Thank you so much for sharing. And that can be a huge challenge of turning people away, is because of some of the increased violence that healthcare workers are experiencing. Now, I want to switch gears a little bit. Dr. Ken Milne, as an associate professor at Schulich and also a Gateway research chair, you have actually participated in a Discovery Healthcare camp that's aimed at recruiting and inspiring young students in rural communities. Can you speak to that a little bit, and how that might be connected to rural emergency department closures?
Sure. This ties to one of the smartest people I know in this area, and that's Dr. Sarah Newbury from NOSM. And she gave a Gateway lecture on recruitment and retention. And so how do you have this quorum, enough healthcare providers or clinicians, whatever you want to term them, how do you have enough people to provide enough care to rural communities? And it comes down to both recruitment and retention, and they're intimately linked. And you can't have recruitment if you can't retain the people you have, because it's so important to have a mentor to show people, this is a great place to work. I love my job. Look at all the cool things you can do. And so what Gateway has done with their Discovery Camp is every summer, I think it's been, Sage, for about a decade now, they invite high school students, so pre-med, pre-university, pre-that, and say, take them for a summer camp and have various clinicians come in, whether they're nurses, physiotherapists, social workers, or physicians, and others, to come in and give a talk, show them. For me, I come in and I do a casting clinic, and we get out the plaster and we have a lot of fun. We put our hands in buckets of water and we walk out of there with casts on, and it's just a lot of fun and the enthusiasm. And I've seen people come through that program now that it's been running for 10 years, and those people go into healthcare. And we have good data from Dr. James Rourke from probably 30 years ago, showing that if you train people in their local community, they're more likely to, stay in their local community. NOSM, the Northern School of Medicine, took that to a whole nother level in the North and have recruited people from their home communities in the North. And those people, they have data that those people are more likely to stay in the North, because you don't take the person out of the farm, right? You don't take them off the land. You train them on the land they're going to be practicing in. And so from Gateway's perspective, this has been a sort of an initiative with this discovery. You could discover, I want to be a laboratory technologist. I could discover, I want to be a pharmacist. I could discover, I want to do nursing. I could discover, I want to be a PSW. And so at the root of it is this idea that you can grow your own. And my only criticism of Gateway, well, the note I'll give, the friendly amendment, the suggestion would be, high school is still too late. We should be starting even before the 8th grade and showing young people that they could be involved in the health and wellness of their own community.
Thank you so much. We are about to do a little bit of a speed round to answer the last few questions. So if you can keep it to 30 seconds, I know you guys are all great speakers. So I'm actually going to ask Dr. Fraser MacKay about burnout. So there's a high rate of burnout for emergency physicians, the highest of all specialties within medicine. How do we mitigate some of that, or how do we prevent the burnout of our providers?
We mitigate that by collaborating across the system so that we don't feel like we're isolated and we're having to do the job of the entire healthcare system. How do we do that? You know, there's a lot of unsung heroes out there doing huge work on all these things we're talking about. Dr. David Savage in Ontario, doctors across the country that are putting so much effort trying to get actionable plans. But really, the big part of it is we need to feel that it's not us against them. For everyone listening, I honestly think if this is something you believe in, if you work in an emergency department in any capacity in anywhere in the country, join the SRPC and join CAEP, right? Pay the membership and come on board, because yes, we've got great conferences, we've got great learning opportunities, but ultimately we are organizations with huge influence to advocate for these changes. Governments listen to us. Health authorities listen to us. The more members we have, right, you will be invited to participate, to add your voice. And that goes a long way to feeling that the work you're putting in is being appreciated and it's worth it.
Okay, and one final question to Dr. Sarah Giles. Jimmy True, actually the local hospital CEO, has asked about the postal code medicine model to connect all Ontarios to primary care physicians. And I know Dr. Fraser said, hey, primary care, emergency care, not necessarily the same thing, but what do you see about maybe the benefits and the risks to that model, if any?
Ideally, everyone in Ontario has a primary care provider. That could be a nurse practitioner or a family physician. That's great. I think what is sort of missing from this model is understanding that family physicians in our system do so many different things. So my hospital in Kenora, there's about 40 doctors here, and everyone does a few things. So they might do primary care, but they're also in the emergency room, but they're also a anesthetist who delivers babies, who does C-sections. And we need, if we want to have that model, we need to actually massively overpopulate the number of family physicians in rural communities, because we don't have the specialists running our hospitals. We're doing everything. So we need to create a lot more family doctors, which means, and those aren't, nurse practitioners aren't doing the hospital work by and large, okay? Which means we need more residency physicians, which means we need more medical school physicians. So it's not a simple problem to face. And we have to understand that the pipeline takes a good 10 years. What are we doing in the next 10 years to in the interim? We can't just be like, oh, let's sit back. In 20 years, the number of people over the age of 80 in Canada will triple. Okay, will triple. We're working on building a new hospital here in Kenora with the same number of beds. It's not going to work.
Now, as we come up to the end of this webinar, there are researchers that are studying some of these topics right now. Dr. David Savage found that the number of hours of closures is increasing. According to his conversation with the CBC, 2024 was the worst reported year for closures, and we don't have the full grasp of the data for 2025. And I would invite you to give me a 10-second wrap up, starting with Sarah Giles, and passing it on about final thoughts.
I would say that the data, however bad they look, are actually far worse, because as Fraser said, we're not capturing so many closures. We're not calling doctors, camera with no ability to put in a chest tube, intubate a patient. We're not calling that a closure. So I think if you're alarmed, you actually should be terrified.
Okay, I'm going to give a more positive spin, only in that, as Sarah said earlier, this is a great job. It's really hard right now, but we can either stick our heads in the sand and collapse and quit, or we can come together and work. One of the attendees today is Dr. Rob Dunfield. Yesterday at the last minute on shift, CBC asked me for an interview about the closures in BC. And I said to Dr. Dunfield, can you stay a little bit late so that I can do this interview? And he said, of course, this is important work. And that's huge, right? Encourage people to take on this work. Encourage your colleagues to join and make, if we all come together, we can make things better, but it takes everyone working together.
Do I get 10 seconds? Okay, here's 10 seconds. Emergency medicine is the lighthouse in the house of medicine that's supposed to be always on for anyone, at any time, for anything. And we should think long and hard about the implications of turning out that light.
So thank you to all the presenters who have joined us for today's webinar, and thank you to the audience. We would also like to thank the following sponsors for their continued support, because without them, the lecture series would not be possible. These include Hurontel, Lighthouse Money Management, DeJager IDA Pharmacy, Zehrs Goderich, CIBC Wealth Management, Libro Credit Union, and Tuckersmith Communications. Gateway is a not-for-profit with charitable status, and we greatly appreciate any support you can give us. We will return on September the 9th, 2025 with our regular webinar series, and we look forward to seeing you there. I wish everybody a great day. And that's all, folks.
Thanks so much.